Welcome to History of Retina's Leaders and Legends series. The purpose of these interviews is to capture first-hand stories from individuals with unique retinal insights of historical significance. Through these discussions, we hope to provide a fuller understanding of the evolution of the science and practice of retina through the lens of those who have lived it. Today I'm delighted to be chatting with Dr. Stanley Chang. Stanley is the K.K. Tse and Ku Tae Ying Professor of Ophthalmology at Columbia University Medical Center in New York. Born in Shanghai, China, Stanley and his family immigrated to the United States in 1949 when he was 2 years old. He went on to earn an electrical engineering degree at MIT in 1968, followed by a master's degree in biomedical electronic engineering from the University of Pennsylvania and a medical degree from Columbia University College of Physicians and Surgeons in 1974. He completed his ophthalmology residency at Massachusetts Eye and Ear Infirmary in 1978 and his fellowship at Bascom Palmer Eye Institute in 1979. Stanley is perhaps best known for his development of perfluorocarbon liquids, a product that revolutionized the process of repairing retinal detachments, particularly those associated with proliferative vitreoretinopathy and giant retinal tears. He also played a pivotal role in the development of a panoramic vitreoretinal surgery viewing system and the subsequent education of retina specialists around the world on the merits of this novel technique to improve outcomes of vitreoretinal surgery. With all these accomplishments, it comes as no surprise that Stanley has received numerous honors and awards, including, to name just a few, the American Society of Retina Specialists Helmrich Award, the Club Jules Gonan Herman Wacker Prize, the International Council of Ophthalmology's Jules Gonan Medal, the AAO Lifetime Achievement Award and Charles Scapin's and Jackson Memorial Lectures, and most recently, Stanley received the American Academy of Ophthalmology's highest honor, recognition as its Distinguished 2024 Academy Laureate. Stanley, what a wonderful and fitting honor. Thank you so much for joining me today.
Thank you for inviting me.
Let's start at the beginning of your personal story. You're one of 3 children born in Shanghai, China, where your dad was an engineer, and your mom had her hands full with 3 young kids when your family came to the United States, where you all eventually ended up in Brooklyn, New York. What led to your parents' decision, one, to bring you to the United States, and how did you end up in Brooklyn?
Well, my parents were in China at the time of a civil war in Shanghai, and they had noticed that the political and economic situation was changing rapidly. And my father made the decision to come to the United States and bring his family. And I'm lucky that all of us were able to leave on one of the last ships leaving Shanghai, because a few months later, the communist party took over China and declared the People's Republic of China.
And how did you end up in Brooklyn? Did you know people there?
Well, my father had a job lined up in Manhattan, and so he needed a place to live, and we ended up in Brooklyn as the first place we moved to.
And you went to college at MIT. You studied electrical engineering. What led to the kind of transition from an engineering potentially career into medicine?
I enjoyed science, so I thought engineering would be the field that I would enter. And my father, because he was an engineer, was a good role model for me. And I intended to go into bioengineering. But as a bioengineering student, I realized that you really didn't solve the problems of medicine unless you were a doctor and understood the problems that patients were facing. And I wanted to deal more with, interact with patients rather than with instruments and oscilloscopes and voltmeters.
So that took you into medical school. What led to your decision to go into ophthalmology?
Well, ophthalmology has tremendous technology, right? So we're the first to use lasers in medicine. We have very precise surgery, and that attracted me to be able to do surgery as well as have a medical side to caring for patients.
Had you gotten any experience in ophthalmology or worked with people in ophthalmology when you were in medical school?
Yes, I did. I was introduced to ophthalmology by when did a research rotation with Jackson Coleman and David Abramson. David was a resident at the time, and he was a tremendous role model, got me involved in my first paper and first presentation at ARVO, an amazing person. And Dr. Coleman, of course, he then gave me my first job when I finished training.
So that was one big decision you made during medical school to go into ophthalmology, but you made another big decision during medical school, and that was you met your wife there, right?
Yes, I met my wife, and we were married during my third year in medical school. She worked and put me through the fourth year, and then we went on to residency. She gave up her career as a Wall Street analyst down in on Wall Street when we moved to Boston.
Wow, that's a big sacrifice.
That was a big sacrifice, and I owe a lot to her, not only because she was with me these last 53 years or throughout my life. She's been very supportive.
Your ophthalmology residency at Mass Eye and Ear was from 1976 to 1978. Can you talk a little bit about that period of time and what led to your decision to eventually go into Retina?
It was a wonderful time because I had really become interested in ophthalmology and particularly in the area of ultrasound. I had done some work with Jack Coleman. It gave me an opportunity to do ultrasound studies during residency. So I became interested in vitreoretinal surgery as a result of the work in ultrasound. And during that time, there were wonderful co-residents. Mark Yoshizumi, who taught me how to do scleral depression, who later became professor at Jules Stein. Many other residents, Steve Felden, who became chairman at University of Rochester, really became leaders in the field, and they were an amazing group of young people to be peers with.
And you did your Retina Fellowship at Bascom Palmer from 1978 to 1979. Robert Mockemer had just left to go to Duke as chairman there. Tell me a little bit about your time as a fellow there, and was there any residual impact from the great Robert Mockemer after he left?
I really enjoyed going to Bascom Palmer, and I was interviewed by Robert when I was applying for the fellowship, and unfortunately, when I got there, he'd just gone to he'd just left for Duke. And, but the program was fantastic because it was like a family. Bascom Palmer was much smaller there. The leadership of Ed Norton really created a family-like atmosphere. In contrast to Mass Eye and Ear, which was much larger, and there was a lot of different groups vying for power. And it was an incredibly different atmosphere and culture that had been present at Bascom Palmer. I was fortunate to have many wonderful mentors there. Vic Curtin, who taught us retinal surgery with Don Nicholson, Mary Lou Lewis, and Don Gass, who occasionally did cases in retinal detachment. And then the surgery service led by George Blankenship, John Clarkson, Mary Lou Lewis, and two young faculty members then, Harry Flynn and Gary Abrams, who were just wonderful young mentors for our fellows.
And did Robert Mockemer ever come back and give talks, anything like that?
Yes, periodically, Robert still had connections with Jean-Marie Perel, and he would come back periodically, and it was wonderful to interact with Robert. He's a surgeon, an amazing thinker. So it was a real pleasure to visit with him. And Ed Norton was an amazing leader also, who pioneered SF6 gas.
So my understand is, obviously, while he was there, the majority of folks were using the VISC. And then the Occutome came with Harry Flynn. So during your fellowship, were most people using the VISC? Were most using the Occutome?
I would say the majority of people were using the VISC at the time. But it was amazing how they could use this big instrument and do such precision work. It was limited, of course, but it was really quite amazing when you come from residency where they didn't have much vitrectomy at the time.
So what were the advantages of the ocutome? Why did that become popularized over the visc?
The ocutome was good because it split the incisions into 3 small incisions, and you could then manipulate the eye and move the eye more easily. And that was a plus to the ocutome. Then, of course, when 20 gauge endo laser came about, then it became much easier to interchange instruments at 20 gauge.
Then you finished your fellowship in 1979. You joined the faculty at Cornell. What led to the decision to go into a university-based setting rather than private practice?
Well, I knew Jack Coleman from medical school, and Jack became the chairman at Cornell Medical School. And I always wanted to stay in some capacity to be able to do research. So Jack offered me a job, and I immediately accepted. I had no other interviews, and I was pleased to just join him at Cornell as his first faculty member.
Was it difficult or easy to start your practice? In that setting, there were people in private practice. Was it easy to increase your patient base, or was it a bit of a struggle?
It was a bit of a struggle because there were quite a few retinal surgeons in New York City, and I was relatively unknown, of course, being new. But I got along with people, and gradually it took time, but gradually my practice grew.
And how were the relations between people in private practice and the university back in those days?
So I was one of the first Bascom Palmer graduates to move to the New York area, and I found that most of the other retinal surgeons were of the Scapin school, and that's what created some conflict or between the different philosophies of retinal surgery.
And is that because they were suspicious or displeased with how the techniques you were going to use to fix retinal detachments, or something else?
No, I would say they felt more strongly in the Scapin's philosophy of doing a big, broad buckle, making sure that all the breaks were closed, and they didn't really understand vitrectomy as well at the time.
So in the early days of vitrectomy, we couldn't repair macular holes. So there were the more complex cases that you had. On average, how long would it take to do a case, and how many cases might you be able to do in a day?
Well, I would say that it took probably about 2 hours, 2 to 3 hours to do a case. Even a simple vitreous hemorrhage would take about 2 hours
And that's using the ocutome.
using the ocutome.
So why did a vitreous hemorrhage take 2 hours using the ocutome?
It took long because we had to cut into the conjunctiva and suture in the ports, and the cutting rate was only 600, the fastest cutting rate. The illumination was poor. We didn't have panoramic viewing. We had little prism lenses to get into the periphery, and all of these took time to do the procedure. And we were probably able to do 3 to 4 cases a day.
You switched from the irrigating
Right.
lens to the sew-on lens,
I didn't sew it on. I just put a floating lens with a layer of heel on.
but that was way more recent, right?
No, I was one of the first to implement that
Really?
because I got tired of the irrigating lens caused a lot of corneal
Yeah.
edema, and you ended up scraping the cornea.
Did you go straight from that to the floating lens, or you went to
Yeah,
a
I went
sew-on
from
lens
that.
first, right?
No, I never used a sew on because I didn't want to spend the time sewing it on. And I found that there was a prismatic effect using a floating lens to help you see in the periphery a little bit better. So I
Interesting.
never migrated to the ring.
So in 1984, you presented a paper at the Veil Vitrectomy Symposium on the topic of perfluorocarbon gases for management of massive preretinal proliferation. What was the research that led to that talk?
I had a mentor, Harvey Linkoff, who discovered the perfluorocarbon gases. He did mainly scleral buckling surgery, but he wanted us to use C3F8 in vitreous surgery because he thought it would be helpful for difficult cases. And of course, when I got a few failures or recurrent detachments after the initial vitrectomy, I felt maybe we didn't have a long enough gas tamponade, and I started using C3F8 gas.
And were there any substantial complications with that? Any downsides to using it? Was there any delay in other people picking it up? Then you had to convince them of its value?
Well, the main problem was that the patients had to keep their head down, and we couldn't predict the expansile volume of the gas. So until Gary and Tom Auberg worked out the non-expansile concentration of C3F8, we were always watching the pressure very closely and the size of the gas bubble. And when I first presented a paper on C3F8 at the Gonan Club meeting, they were ridiculing me because they would convince that patients couldn't keep their head down for a month.
Then in 1985, the focus of your research shifted from perfluorocarbon gases to perfluorocarbon liquids. Tell me about that.
We always wanted to look for a material that was heavier than water, and Harvey Linkoff had worked in perfluorocarbon gas. We knew it was pure and inert, and so as the chain increased longer, they became liquids that had higher density than water. We thought that these might be used as heavier than water vitreous replacements. I had a fellow who went to West Virginia University, Neil Zimmerman, who we started working on this together, and he did some preliminary experiments in animals and rabbits showing that this might be useful. And he thought this was interesting and told me to work on this as well. And we decided to work on this at Cornell.
And you were obviously set up with a lab and space and time to do all of this, huh?
Yes. With the funds I had generated from practice, initially supported my research by hiring a technician and paying for the animals and doing the research from the clinical revenues that I generated, but also had the support from the department to uh, bring a team together to develop perfluorocarbon liquids because we knew it would probably be useful. And when I started doing these rabbits, I found that whenever I got an iatrogenic retinal detachment during the surgery, as soon as I put the heavy liquid in, it would flatten the retina. And then but if I left the liquid in permanently, it would form a lot of different bubbles and disperse and probably not be so useful as a long-term vitreous replacement. But because I was doing the surgery and found that I immediately fixed the detachments, I felt that this was the place to use perfluorocarbons as an intraoperative tool and replace it with a gas bubble or silicone oil.
So do you remember the first incidents where you moved from using perfluorocarbon liquids in the lab into the clinic, into the surgery?
Oh, absolutely. I had been taking care of a young patient with a giant retinal tear of 270 degrees, and we were about to use retinal tacks, which was investigative at the time, to try to reattach the retina. We went into surgery, and Harvey Linkoff was very interested in the case, and he assisted me. And when I put the first tack in, there was tremendous bleeding. And for the next 10 minutes, we couldn't clear the eye. We were waiting for the bleeding to stop, and we were wondering, how are we going to do this without tacks, because the first tack was so catastrophic in terms of its outcome. And he wanted to use heavy silicone oil, which he had in his office from Europe. He had brought that over from Europe. And I had just purified some perfluorooctane that I knew was working well in our animal studies. And I thought, this is the only way I'm going to fix this eye. And fortunately, when we put it in, the retina attached beautifully. We were able to reattach the retina. But unfortunately, the patient redetached later on because of PVR.
And so if that case were taking place today and you had the perfluorocarbon liquid in your lab, is there
It would,
any scenario where you could
right.
possibly take it from your lab and put it in this
It couldn't
patient?
be done now. It couldn't be done now, but we had to talk to the patient afterwards and patient's family, and we got the permission to go ahead afterwards.
And then you obviously went on to, perform lots of clinical trials looking at, the use of perfluorocarbon liquids for the repair of retinal detachments. Once it became obvious that this was an invaluable tool to be used for certain retinal detachments, was it a pretty easy path to commercialization to make this available for everybody?
No, it was very difficult to commercialize the product because we're a small it's a small product. It's not a product that generates a lot of income for drug companies. So when we first tried to commercialize it, we tried to get Pharmacia interested. They were the marketers of Helon and the developers of Helon. We could not interest them. They held on to this idea for close to a year before making a decision not to accept it. So we founded a small company, or someone founded a small company, and I helped them develop the clinical trial and get this through the market. It was one of the first. It was the first product, but one of the fastest products to get through for FDA approval, because in the meantime, many people were using perfluorooctane off-label and confirming our findings that this was a useful product for complex attachments. And there was nothing else. So it was one of the products that within, I would say, 2 or 3 years, we got the approval, which is pretty rare for a drug company to get such a fast approval.
Yeah, that's pretty rapid. You remained at Cornell until you were recruited to become chair of ophthalmology at Columbia in 1995. That's a position that you held through 2012. During your time there, you trained numerous world-class ophthalmologists, many of whom have gone on to careers in academics, including several chairs of ophthalmology departments, as well as the current director of the National Eye Institute, Michael Chang. So you've certainly been inspirational to people fortunate enough to train with you. Can you tell me a little bit about what goals you had for the department when you became chair in 1995, and what changes did you implement that you feel helped you achieve those goals?
When I became chair, I had Ed Norton as a role model, and that had a tremendous impact on me. And Ed Norton and Vic Curtin gave me a lot of advice about how to run a department of ophthalmology. First, I wanted to make sure that we had compatible people who got along well. And I was fortunate to have recruited great people. And what made it fun was they were smart and agreeable, and they had a great spirit of wanting to try to build a great department together.
You were instrumental in the development of wide field viewing in vitrectomy surgery. What led to your involvement in that?
Well, I was tired of using 30-degree field lenses, and was doing a lot of PVR and retinal detachment cases. So I really needed a better viewing system. When the Volk quadrispheric lens came out for laser procedures, I thought, why couldn't we use this and see it in surgery, and we could get a much wider field of view. So I began thinking about how we could use this lens in surgery, and I ran into Avi Grindblatt, who was interested in the same concept, and he had already developed an inverter, and so we began working together. We began to miniaturize the lenses and develop the principles and optical formulas for developing small lenses for vitreoretinal surgery together. And it turned out that it was very helpful. In 1992, for my Wacker Prize lecture at the Club Jules Gonin, I presented a video of this concept where we didn't have very much video at the time. We bought a video projector. We edited. Avi helped me do video editing, and we made a 30-minute video tape. Simultaneously at that meeting, Manfred Spitznaz showed his biome, and he also he also showed me his ideas and concept of wide field viewing, which are exactly similar to mine. Unfortunately for me, the biome took precedent for many people because they didn't have an assistant, but I was convinced that the contact lens system gave us better and sharper images.
But you're widely recognized as the person that spread the gospel of the value of wide field viewing for vitrectomy, because without being able to see the value of that through a video like that, you're recognized as the reason that people picked it up. But the adoption of it would have been so much slower if it couldn't be demonstrated as well as you did.
Yeah. And so that was key to video presentation at the time. I thought that having video so people could actually see what we saw in using the panoramic system was vital to its adoption by vitreoretinal surgeons.
We've talked a lot about little details of your professional career. Pulling back a little bit, what would you say are experiences that have shaped you the most during your career?
I would say the experiences of starting something in the lab as a concept and seeing it through as a successful product used by people around the world has been most exciting to me. This, as well as the wide field viewing, sometimes it took a lot of persuasion for people to use wide field viewing, but now it's become incorporated in our daily surgeries. And this is kind of most rewarding to see something that you saw as an idea and people are using it.
And one of your children, Jonathan, actually went into medicine and ultimately went into retina. Tell us about that.
Well, I was lucky that Jonathan, after working in advertising for a number of years, decided he would go to medical school. And he surprised me by choosing ophthalmology as his specialty and retina surgery as his interest. He did his residency at Bascom Palmer and fellowship at Bascom Palmer, and is now on the faculty at the University of Wisconsin in Madison, where he's associate professor. I'm very proud of him.
Wow, fantastic. Now, all of your colleagues that have children that are in college are dying to know, did you suggest a career in medicine? And all of your colleagues with children that are in medical school are dying to know, did you suggest that, Jonathan go into ophthalmology, or did you take the approach, don't say anything, let him make the decision on his own?
The children never listen to their parents, so any suggestions you make might not be accepted readily. So I just let him choose what he wanted and surprised me by choosing ophthalmology.
I think that was a wise decision. It's no surprise because he looked up to you as a role model, and why would he not want to follow you?
Well, I think he was impressed by how collegial everyone is in our specialty and what good friends I had throughout in the field. And that was a big factor in his decision to pursue retinal surgery.
So looking ahead 25 years, where do you see the field of retina going? How are we fixing macular holes and retinal detachments? What are we doing? Is there a therapy for folks with geographic atrophy to actually improve their central vision? Or all those patients we have with fibrotic macular scars because of years of wet AMD? Where do you see things going?
I would say hopefully there will be something better than gas and silicone oil to fix retinal detachments that close the break and will fix the retinal detachment. To me, that's something that will be a big contribution and also something that will improve the vision of macula off detachments.
You think we'll be able to remove macular scars and transplant tissue that will, develop, communications with the host retina, or do you think that's a pipe dream?
I hope so. I hope we'll be able to do something to regenerate that tissue.
That'd be remarkable. Your career has had so many high points. Are there any particular that are uniquely noteworthy?
I would say that I was very lucky to have entered this dynamic field of retina at a relatively young time in my career and met many mentors and colleagues who became wonderful friends, and I had many trainees who became very successful in taking care of their patients as well as I could.
Stanley, your contributions to our field have undoubtedly led to improved surgical outcomes for millions of patients across the globe, making your impact on our field of retina simply legendary. Thanks so much for chatting with me today.
Thank you, John. I think it's been a pleasure for me to really educate the people and participate in the education of the next generation of retinal surgeons.